Thank you for the invitation to present, and I would also like to welcome my co-presenter, Dr. Kim Leighton. So if we could also share her video, that would be wonderful. So again, thank you for the opportunity to present today at your esteemed scientific assembly. And we'd also like to offer congratulations to all of the award winners. That looks like a wonderful celebration. Congratulations. I'm going to share my screen. So today our talk is on supplementing clinical exposure with simulation. How do we get there? Again, my name is Tonya Schneidereith. I am an associate professor at the University of Maryland School of Nursing in Baltimore, Maryland in the United States.
And I'm Dr. Kim Leighton. I'm executive director of the ITCON Clinical Simulation and Innovation Center in Doha, Qatar. Thank you for having us.
On our disclosures, I, Tonya Schneidereith, am Chief Executive Officer of Simple Simulation LLC. It's a simulation company based in Baltimore, Maryland in the United States. And Dr. Kim Leighton has no disclosures. So we have about 20 minutes to provide tips on how to supplement clinical exposure with simulation. In that time, we hope to address these 3 learning outcomes. To describe 3 benefits to supplementing clinical exposure with simulation, to summarize findings from systematic reviews of clinical learning outcomes, and to identify at least 4 criteria of the healthcare simulation standards of best practice simulation design.
Imagine being the clinical instructor for the brand new students who were responsible for providing care to patients on an orthopedic trauma unit. The patients included one who was hit by a train with multiple fractures, an elderly woman who laid on her floor for 5 days after falling and breaking her hip. She had rhabdomyolysis and required dialysis. Another young man fractured both heels after jumping from the 3rd floor in a suicide attempt. These random learning opportunities were not at all appropriate for my brand new students. However, these experiences can be supplemented with simulation in a controlled environment where educators can create and facilitate learning experiences appropriate to the level of the learner. The research clearly shows that with well-designed simulation experiences, we can improve higher order thinking skills such as critical thinking, clinical judgment, and clinical reasoning. We can also create situations that support learners to enhance their non-technical skills, such as communication, prioritization, delegation, and teamwork. Think of a high-risk, low-volume patient, such as one with pulmonary edema. Now, time is of the essence with this diagnosis, but learners might never see that type of patient. So we can create this patient in the lab and allow all learners to assess and treat that patient. Even high volume patients, like those with heart failure, should be in the sim lab, as many learners won't see this patient while in school. Additionally, we can repeat scenarios as often as we need, allowing learners to make mistakes and learn from them, something that we cannot do in real life. There has been extensive research to identify how well a variety of learning needs are met in simulation. Simulation has always been held to a very high standard, especially since the cost can be so high. We were curious, though, as to what learning outcomes were associated with traditional clinical education. We conducted a systematic review of the quantitative research literature and found no evidence at all that the way we have conducted clinical education for decades actually improves learning. This resulted in what is known as an empty review. So we thought, well, maybe the answers are in the qualitative literature, but we found only 6 studies, and the results didn't allow us to form any meaningful conclusions. At the same time, our colleagues, Sharpnack and Kavanaugh's ongoing research shows that newly graduated nurses are just not ready to take on their roles after graduation, and their readiness decreases every year. In 2015, only 23% of new graduates in this study were competent. In 2020, it was down to 9%. This is very concerning, but we believe we can make a difference through the targeted use of simulation.
So as we begin to think about how to supplement clinical exposure with simulation, getting there should include implementation of evidence-based standards. Multiple organizations have created evidence-based standards that can be used to guide implementation of simulation. The Society for Simulation in Healthcare has accreditation standards which provide benchmarks for simulation experiences and programs. Other organizations, such as the Association for Simulated Practice in Healthcare, the Association for Standardized Patient Educators, and the International Nursing Association for Clinical Simulation and Learning, also known as INACSL, have standards of best practice to guide the design of our learning experiences, how we implement them, and how we evaluate them, and also how we manage operationally. Dr. Wilson Keats will be speaking next about the newly released standards from INACSL, the Healthcare Simulation Standards of Best Practice, which apply to all healthcare professions. This is the 4th edition of the standards, which were first published in 2011. They were developed by multidisciplinary teams and have been endorsed by over 20 organizations worldwide. Today, we will focus on a portion of the 11 criteria that comprise the simulation design standards. So we're focusing on the simulation design standard because it provides a framework and roadmap for developing effective learning experiences. As we break down this standard, you will see how it allows focus on specific aspects of the experience. It integrates best practices from adult education, clinical standards of care, and simulation pedagogy, to name a few. It allows for alignment between the simulation experience and the program goals and institutional mission. If you're considering SSH accreditation, demonstrating this alignment is part of the program management criteria. It also provides a systematic process that is purposeful and flexible. There are 11 separate criteria within this standard, but for the purposes of this presentation, we will expand upon a few of these.
To demonstrate the simulation design standard, we're going to apply a select few of these criteria alongside a simulated case to help conceptualize application of the standard. Now, this is Mr. Jones. He was a 35-year-old male on his way to work, and he was injured in a motor vehicle accident. Upon arrival to the ER, he was diagnosed with a liver laceration, and that resulted in significant blood loss that required a blood transfusion. But what happened next is the foundation for the creation of the simulation experience. The patient had a blood transfusion reaction. So we set out to learn more about this incident so that we could create our scenario based on the identified learning needs. So we did a needs assessment and interviewed key personnel. Let's see what they have to say.
Oh my gosh, it was so busy that night. I remember we had several trauma patients that it was very difficult to keep up all the orders. Each time I got a call, I put that patient's blood bags on the counter. So the nurse can pick up them even if I am busy with other rooms.
Oh, we were really busy at that night because there was a huge accident on the roadside and we got a lot of patients. So, and then we were short of some nurses as well because some nurses went for the COVID side to support the COVID patient. So I got all in sudden like a call for the blood. So I ran to the blood bank. So usually we give for the trauma people O negative. So I saw there some bags. It's written as O negative. I just grab it and come back to the ward and I just give that blood to the patient. So the take person was not available in the blood bank because he was busy with another room. He was preparing some blood for the other patients.
I noticed also that there is no evidence that the blood was checked and the form was signed from the blood backpack and the nurses to check if the blood, it was for the right patient and it was the right blood group for him also. Another thing, what I noticed also, that there is no cross match before addressing the blood to the patient, and that's why the patient received incompatible blood and had a reaction.
Well, as you can see, the policies and procedures for administering blood weren't followed. So this will be the focus for our simulation design.
Oh my.
Now that we knew the issues as a result of our needs assessment, as simulationists, we need to meet with content experts to ensure that our simulation is realistic and accurate. Some of us have been away from this practice environment for quite a while, so we need to make sure that we understand the current policies and procedures related to blood transfusions. I'd like to point out that there is also a new standard for professional development of simulationists that you'll want to read.
In coordination with content experts, a backstory, script, clinical progression, and cues should be developed to help place the learner in a realistic clinical situation. Using a video like this one can help add to the psychological fidelity. When we consider a patient recently involved in a motor vehicle crash, pay attention to the car on the right side of this video. Notice the deploy of the airbag, and then use that image to feed into the description of what the learners will encounter in the simulation. And so following that, we are moving into the objectives. Objectives should be written for the learners that are specific, measurable, achievable, realistic, and timely. So an example of the objectives for the motor vehicle crash could include identify 3 steps of closed-loop communication, describe 2 barriers to effective team communication and collaboration, and to articulate systems currently in place to avoid medical errors. Again, I cannot emphasize strongly enough the importance of making sure that your objectives are measurable, because when it comes time to evaluation, you need to understand and make sure that your learners have achieved these outcomes. Next is the modality. The modality is directly related to the objectives. And so if you are running a simulation that mostly involves communication, you'll want to include a standardized participant that can include both verbal and nonverbal information. If you're doing skills, then a task trainer would be important to use. This criterion is also used in conjunction with fidelity. Fidelity is related to a perception of realism. So in our simulated case, the simulator was moulaged to show bruising from the seatbelt. And then we also used bags of packed red blood cells to allow for realistic application of safety measures. The simulation should be at a level that's appropriate for the learner. They should have prior exposure to the content and the ability to achieve the expected outcomes. For example, novice nursing students would not be expected to act appropriately in a resuscitation scenario. However, a resuscitation scenario would be appropriate for graduating nursing students.
It's important that the learners understand what is expected of them when they come for simulation. Consider again the level of the learner. What is it that they need to know in order to be successful? Have you presented this material in class? Have they experienced this type of patient situation in clinical? Think about how the learners might prepare ahead for this patient. If using my new students as an example, I would want them to read about communication strategies, especially with other team members. I'd also want them to review blood types and interactions, as well as the local policies and procedures for transfusions. Now, pre-briefing is an intentional discussion with the learners that occurs before the experience starts, and it's intended to balance the cognitive load demands and to set the ground rules so that all learners have a common mental model. We also want to decrease learner anxiety and increase psychological safety. One way to do this is by adopting the basic assumption, which reads, we believe that everyone participating in activities at our simulation center or lab is intelligent, capable, cares about doing their best, and wants to improve. There are many required elements for briefing, which include setting expectations, such as the length of the scenario and the debriefing, the break times and agenda, ground rules, fiction contract, establishing confidentiality, discussing the method of evaluation, reviewing objectives, as well as orientation to the sim environment and the equipment and how it's used. Now, that's a lot to remember. We use a template at our center so that we don't forget any of those things. Now, debriefing is a vital component of the simulation experience, where we guide learners in a reflection of their actions or their lack of actions when they're caring for the simulated patient. We help them to explore their decisions and actions by using certain types of questions to help them reflect. For example, I noticed that you didn't check the patient's armband before hanging the blood. Can you tell me what you were thinking at that time? Asking questions using this advocacy inquiry approach helps us to manage our own biases too. We might think they just forgot, while there may be many other reasons that should be explored. Using open-ended questions like, tell me more, are also helpful. There are several debriefing models, which I'm sure you'll learn more about in other sessions. There are several methods of evaluating the performance of the learners: formative, summative, and high stakes. A formative evaluation occurs in simulations used for learning purposes. Remember, we learn more from the mistakes we make than when we do everything right. However, it's important to have feedback and guidance from trained facilitators to address those errors. Summative assessment occurs at the end of a period of time, perhaps at the end of a semester. Now, high stakes assessment is similar to summative, however, there are consequences. For example, if the performance is poor, there may be a grade assigned, or perhaps the learner is not able to advance in a course or even obtain licensure. These are high stakes outcomes. So what do we evaluate? Well, it depends on the learning objectives. For this patient, we would evaluate their understanding of closed loop communication, the steps and barriers, as well as systems analysis. These are all cognitive evaluations, which we can assess through observation as well as the debriefing discussion. If we want to evaluate performance, then we can use rubrics and checklists to evaluate that. However, we need to make sure of two things. One, the evaluation tool should be validated with the group that you're training. For example, using an evaluation tool that was validated with practicing physicians with a group of nursing students would require validity work. The evaluators must use the tool the same way. This requires integrated reliability training for the evaluators. And this is vital if the simulation results in high stakes outcomes. Two places to find evaluation instruments are the INACSL, International Nursing Association for Clinical Simulation and Learning, repository of instruments, and the Evaluating Healthcare Simulation website, where you can download tools immediately and no cost.
Before implementing with learners, the simulation should be pilot tested in the real space with participants similar to the expected learners. During this time, identify any confusing or misleading cues or other elements that may result in an inability to meet expected outcomes. Make changes and improvements based on this pilot. It may not always be possible to pilot test if you're doing just-in-time training or if you have limitations of space or resources that make pilot testing impossible. If we look at the images on this screen, the image to the left is showing the simulator that's used. This is reviewed during the pilot test, as well as making sure that the cues on the monitor, the physiologic cues, are appropriate for the simulation. The image on the right shows some of the supplies that we have available. So during the pilot test, you want to ensure that the medication is available that's appropriate for the simulation, as well as any other additional supplies and methods of communication that are important. So we recognize that this was a very brief overview, but we wanted to provide information on how the Sim Design Standard can help create a roadmap to get you substituting clinical experiences with simulation. So to summarize, today we identified systematic reviews of clinical learning outcomes that demonstrated that these were empty reviews. Supplementing clinical exposure with simulation offers multiple benefits, including those opportunities for repetition, for higher order thinking, and cases that are specific to the learner's needs, as well as the healthcare simulation standard of best practice in simulation design offers a framework for developing specific learning experiences. These are the references that were used. And so again, we would like to thank you for the opportunity to speak at your esteemed conference on supplementing clinical exposure with simulation through integration of the simulation design standard. I think now we have an opportunity. We have a little bit of time for questions if anyone has anything.